most of you know me, but my name's Christi DeLemos, and I'm a nurse practitioner with the Department of Neurological Surgery. I'm also the president of the World Federation of Neuroscience Nursing, and I want to give a quick talk on an introduction to neuroimaging. I'm not a neuroradiologist, so disclaimer, disclaimer, disclaimer. But I think that there's a lot we can learn from imaging. I am going to kind of run through the slides, not so fast, but I am going to not spend a ton of time on each topic. So if there's one that really interests you, an imaging finding, please see me afterwards, and I'm happy to go over it with you. So just an overview of what I want to go over with you today is I want to provide a nice overview of diagnostic imaging techniques commonly used in neuro patients, and also talk to you about the findings associated with stroke, mass lesions, traumatic brain injury, as well as neurodegenerative states. I also want to teach you some really basic skills in recognizing abnormalities on CT and MRI. So I want to start by telling a very short story. My husband and I are totally a team. And so we've been married a really long time, like 28 years. And we thought from the very beginning, on our anniversary, we have to get away. It's so important. It's part of just maintaining that team spirit. So every anniversary, even if we had $0, we would go somewhere. And sometimes it was camping, and that, that has its own fun. And sometimes it was somewhere nice. So one year we decided we would go to the coast, and this was before we had GPS. So many of you know, here's the man with the map telling you, I know where I'm going. We should take this route. And I see, remember how they had the 3 heavy double lines? That meant that's a freeway. And I'm like, the freeway is looking good to me. We're going to the coast. I've never been to this area of California before. I think we should take the heavy 3 lines. And he said, we can get there faster if we take this tiny little dotted line. And I said, well, I don't know if we can get there faster. That looks like a small road to me. And he said, no, we can get there faster. And I said, okay, you're driving. We're going the tiny dotted line. And so we come up on this sign, and I'm like, that looks like rocks falling. And he said, I don't know what that sign means. I mean, it does kind of look like rocks falling. And then it said this, side out. And I'm like, what is side out? I don't know what side out is. And this is what we saw. The side was out. That is definitely a side out, right? I mean, and so important to understand. You only see what you know. If you do not know what you were looking at, it does not matter how obvious they make it. And that's so true in imaging, right? So that's what we're going to talk about. So why do we perform imaging studies? It's really to detect abnormalities in the brain or the spinal canal. It's also to direct the treatment plan. It's to evaluate our response to treatment, and also to evaluate for disease progression. And so I'm going to start with one of the most common imaging studies we do, which is CT scanning. And CT scans are typically with or without an iodine-based contrast. And so that's important. So when we ask you, is a patient allergic to iodine? Because we're worried about that contrast agent that we're going to give them. Also, we also ask you about renal function because we're worried because the kidneys can take a hit with iodine-based contrast. So it's great for things that are super obvious. And it's 10 millimeter slices through the front of the brain, the anterior fossa, and it's 5 millimeter slices through the back of the brain. And then there's also angiography now and venography, and CT venogram is actually the gold standard for evaluating venous flow. So CT angio, this is a great example of an angio that shows an aneurysm, and it's located, I'm going to kind of walk around and show you guys. So you guys see it right there? That big bubble on the middle cerebral artery? So this vessel here is the ICA going up, and it kind of makes that nice turn in the cavernous segment and then comes across as MCA. There's a big aneurysm on the MCA on that side, and then this is the vertebral as it comes up, and it goes up and forms the basilar, and again, ICA over here in the middle cerebral, and the ones that go straight up are the anterior cerebral arteries. And so the next thing I want to touch on is just plain x-rays, because plain x-rays can give us a ton of information as well. And so plain films show a great view of the bony anatomy. And flexion and extension views, you see us doing that all the time in the hospital. And what we're looking for is instability, particularly in a trauma center. That's a terribly important thing. We also evaluate for bony tumors. We evaluate for fracture. It's a nice screening for fracture, although CT imaging is much, much better for looking at fracture. We evaluate for failure of our hardware. Sometimes we'll place hardware and that hardware will fail. The screws will break. And we can also evaluate our shunt settings on this. And so what you're seeing here is actually kind of a slippage of the vertebrae forward. So this is a pretty obvious problem, right? And so this is a CT of the spine, and you see this nice alignment of the spinal bones, and they kind of look like blocks. That's the vertebral bodies, and that part on the back that you can kind of feel on your spine. If you touch the back of your spine, you can actually feel those lumps. That's the spinal process. And so what you see there is you see a fracture dislocation. Do you guys see that, where it's not aligned and it's pushed forward? Now we're going to move to the CT of the brain. The CT of the brain easily detects bleeding, calcification, and then the posterior fossa, not a great way to look at that. Really, MR images give you the best view of the posterior fossa. You also can sometimes see tumors that are calcified, things like meningioma. And then some low-grade tumors are pretty difficult to see on this, and I'll show you a little bit later an example of comparing a CT scan and an MR and what a difference it makes to get that. What you see here is you see a lens-shaped bleed. Do you guys see the one on top, that big white blob? It's an epidural hematoma. And then here you see this kind of star-shaped white stuff. Do you guys see that? Can you see the finding? And that's actually subarachnoid hemorrhage. So before we had MR, CT was fabulous, and now that we have MRI imaging, there's such detail that it provides. Most people really, really like MR images for things like tumors. There are things that CT is great for. If you have a bleed in your head, fabulous. CT is really, really good. If you have a tumor, I'd much rather have an MRI. And so MRs are done with and without gadolinium. And who knows that gadolinium, actually, you have to look at renal function for that as well. So that's really, really important to know that. MR angiography is great because you can actually, with or without gadolinium, look at flow and track the flow and be able to look at the vessels. And it's less detailed than CTA, but still a great screening tool. And then MR venography actually looks at the venous flow. So if you're looking at the sagittal sinus, the transverse sinuses to see if there's something clogging up the works, you can see that on MR. So MRI scan of the brain provides very detailed information on the uptake of water. That's how it works. It actually looks at how the water is moving in the brain. And it looks for swelling, new ischemia, peritumoral edema. It's really best seen on T2 and FLAIR if you're looking for swelling. And there's excellent visualization of the posterior fossa structure. So the brainstem and the cerebellum, fabulously seen on an MRI. Blood is really poorly visualized. So if you're looking, sometimes a subdural hematoma will be really overemphasized. It's not nearly as big as it appears to be on MR. And sometimes it's very difficult to see subarachnoid hemorrhage. So those aren't the best screening tools for blood. So MR imaging of the spinal axis looks at the disc, the spinal canal, the exiting nerves, and it's also great for tumor. And what you see here is you actually see a beautiful view of degenerative disc disease. So you see one disc, the one at the very top is a normal disc. It's full of water. You see how it's white? And that's all that water that's plumped up the disc, and it looks really nice. Then you have one that's beginning to bulge, and you see how it's a little bit more black? So it has disc desiccation. The disc is beginning to desiccate. And then farther down, you see a disc that's actually bulging out into the spinal canal area and herniating. And you see that there's less disc between each bone. Do you see that? That it's kind of flat. And so this is what we see all the time in neurosurgery. These are people that come in complaining of either leg pain or back pain. So I want to just give you a quick metric on how do we interpret a CT scan. So I think it's really critical to use a systematic approach and don't look for what you think is there. That's really important because you'll miss a lot of stuff if you're just looking for, well, this patient has this, so I'm going to look for that. You'll miss some of the other findings. And I always use the acronym, blood can be very bad. And I'll talk to you about what that means. So B stands for blood. We're inspecting the brain for any signs of bleeding. C is the cisterns, which are all the canals in the brain, and we're looking to see if they're open or are they compressed. The brain itself, the brain parenchyma, we're looking for any masses, contusions. Is there any midline shift? Is the brain pushed over one way or another? The ventricles, which is where all the CSF flows, we're looking to see if they're symmetric and are they the same size. And then lastly, the bone. We want to evaluate the bone to see if there's any fractures of the bone. Is there any hyperostosis? And I'll show you a great example of hyperostosis a little later. And then also, is the skull shape normal? Because think of craniosynostosis in children. They have a very abnormally shaped head. So we're looking at that bone carefully as well. So this is an example of looking. So first we're going to look for blood. Does anyone see blood on that scan? Yes, yes. So what kind of blood is there? Subarachnoid, absolutely. So it's filling in all of the little spaces, and it makes it almost look like marble. If you see a scan that looks kind of like a marbled appearance, that's probably subarachnoid hemorrhage. And then next we're looking at the cisterns. On this you can't see them very well. So we'll go to our brain. Do you see any shift one way or another or trauma to the brain? So we're looking at that just behind the orbit. It looks to me like there might be some bleeding behind the orbit. On the left, yeah. And then the ventricles, and then the bone. And so you can see the bone window. Do you guys see the fracture? And there's like this obvious sign that you have this big lump. Do you guys see it? At the very top on the left, which would be considered your left, it looks like right, but it's left. And there's a fracture, and there's a ton of soft tissue swelling around it. And so that's how you know. This is another example of a fracture with soft tissue swelling. So look at the soft tissue as well. So that's an obvious depressed skull fracture. Okay, so I'm just going to briefly touch on each kind of neuroimaging, and first I'm going to talk about neurotrauma. So CT scans are considered the standard of care for all emergency departments for the initial imaging in moderate to severe brain injury. There's a lot of controversy over whether or not we should be scanning people with concussion. There are certain indicators for some people that had a lapse in consciousness with their concussion and or were older or had some sort of neurologic deficit that might warrant CT imaging, but it's not required for all patients. It can detect the most important findings, which are fracture, contusion, hematoma, cisternal compression, subarachnoid hemorrhage, and atrioparenchymal hemorrhage. It's really not ideal for diffuse axonal injury, and I'll show you some examples of that. We really want an MRI, and there's a huge difference in the way it looks. So this is an example of what you can see on a CT scan. What you see on this CT scan is actually on the one on the far left is a subdural hematoma. Do you guys see that? It's holohemispheric. It goes all the way down. It's that white layer that goes all the way down, and I have an arrow next to it to help you. And then the CT scan next to it is diffuse axonal injury. Do you guys see the little white dots that are in the brain? And that's not that impressive. It looks like, oh, well, that's nothing. The patient will be fine. But in fact, they can be really impaired, particularly if it's bilateral, because remember, you're actually tearing the connections between the neurons. So it's an axonal injury. It's tearing it. And so those connections may or may not come back. And then on MR, you're actually seeing diffuse axonal injury. It's the same type of injury, but it's so much more obvious, right, on an MRI. And this just shows blossoming of contusions. This is a patient that came in, and you can see the very, very few findings on the initial scan, and then you can see as the time goes by, there's actually more of the bleeding. So here and here and here, that's all blood. You guys see that? And over here, that's all bleeding in the brain from trauma. And then localization of monitoring devices. This is super helpful also. You know that after we put in an external ventricular drain, and you're like, oh, well, it's not working very well. And then you get your scan, and then you see this. You see this scan. So do you guys see? This is actually the external ventricular drain. It's kind of far down, huh? It makes it hard. And so sometimes you can overshoot the target. There can be bleeding. So it's really important. I think CT scan's a wonderful tool if you have any worry at all about after placement, about being able to use it. Most people do receive CT post-placement, and portable for us, I don't know, it's not that portable. It's kind of hard to get them organized and get them to come and use the portable CT scanner. And they have to be on a special bed at our institution. I don't know, from a show of hands, who's using portable CT? Not many? Yeah, few. Okay. So this is epidural hematoma, and it's classically, just the clinical presentation is classically a lucid interval after a period of unconsciousness. And it's really tempting to leave them alone because they can look really good. They can be talking to you, seeming fine. But the hematoma volume of greater than 30 centimeters and a midline shift of 5 millimeters was associated with clinical decline and failed non-operative management regardless of the GCS. So even if the GCS was good, those people did not do well. And so this is an example of epidural hematoma. Remember, it's lens-shaped. Do you guys see it there? And then over here again, a lens-shaped lesion. This is typically the middle meningeal artery that's bleeding. So pupillary abnormalities, the reasons why we check those pupils, and it's really, really important, is it occurs in 20 to 30% of people with epidural hematoma. Ipsilateral dilated pupil is correctable, and it does not affect clinical outcome if they're operated in about an hour. If you don't catch it and you leave it go, waiting more than 70 minutes after blowing a pupil in the setting of epidural hematoma predicted death. And so it's very, very, very important to follow your exam. And the most common vessel, again, is the middle meningeal. So another thing that we look at in the setting of trauma is always vascular injury, because remember, you get these acceleration, deceleration injuries where people are going really fast and that vessel may have kept right on going and it can tear it on the inside. And it's always should be considered. We're looking for blunt carotid injury, intimal dissection, pseudoaneurysms, and also thrombosis or fistula. So people with a carotid dissection will actually present or can present with a Horner syndrome, which is ptosis, and this is a good example of that, anhidrosis, and meiosis. So the pupil on the side that's affected is actually small, and so that's important, and that's the side that's affected. It's ipsilateral. And this is an example of a carotid dissection. So you get this tapering effect of the vessel. The vessel is large caliber, and then it begins to taper off, and sometimes it'll even just taper off to nothing. And that'll cause a major stroke. So that's important to detect that. I'm going to quickly touch on stroke imaging. We have a lot of stroke experts in the room, and as I said, I started my career in stroke, so it feels like home to me. The hallmark symptoms of stroke, of course, are sudden onset of weakness, numbness, difficulty talking or understanding, balance problems, or a change in vision. This is a horrible picture of a stroke, right? That's a stroke in motion. And I'm going to show you that finding. Do you guys see right here? I'm pointing to it with an arrow. That is the middle cerebral artery. And where is it? It's gone. And so it's clogged up. And so the vessel is actually, is actually right here. It comes in, but then it terminates suddenly, and that's actually the vessel clogged up. And so that's someone who potentially would benefit from IV TPA and perhaps even intra-arterial treatment. So be fast is what we want to be making sure that our emergency departments think about, and that's balance, eye findings, face, is her face symmetric? So that's that 7th cranial nerve. Arm function, remember, arms straight out, palms up, and you're looking for an extremity drift down. And then speech, difficulty talking or understanding, or dysarthric speech, and also the time of onset. So we want to be clear about when did it start, not when did they wake up or when did I find them, but when were they actually last seen normal if someone didn't observe the symptoms starting. So MRI is great in stroke, right? I mean, we don't have time often to do that study, but it is a fabulous study and will tell you a lot. It's highly sensitive for detecting early ischemia. So DWI changes can be seen within minutes of a stroke starting. They're very, very, very sensitive and specific for stroke, 90 to 100%, and it often, sadly, takes too long. So we're not able to get people to an MR scanner. We have to rely on clinical exam, their history, and also the CT scan before treating with TPA. So this is an example of what we might find on CT scans. So if someone told me the symptoms started 10 minutes ago, And this is my scan. Do I believe them? No. No. That is a large vessel stroke. That is at a minimum the whole MCA, right? And so that's the entire left MCA. That's a dominant hemisphere, and that's a big problem. If someone said, if I'm over here, my symptoms started an hour and a half ago, maybe, okay. They've got a little bit of hypodensity. If you look at the scan, they've got a little bit of hypodensity, early hypodensity in the middle cerebral artery territory, but it looks like a branch rather than the entire distribution, right? And then here, they say, my symptoms started an hour ago. What are we doing? Not TPA, right? That is a ton of bleeding. And so that's time to call someone from our team, the neurosurgery team, just to look at the scan. We're probably not going to do anything about that unless you want an external ventricular catheter put in, because this is not someone, this is deep hemispheric bleeding. They often don't benefit from neurosurgical care. The people that do are the people that have cerebellar hemorrhages or superficial hemorrhages. Those are much more likely to maybe benefit. If this is a really young person, that's a dominant hemisphere, and so even like hemicraniectomy is questionable, because are we going to really help them if we end up with someone with a dominant hemisphere, very large hemorrhage? So intracerebral hemorrhage, I want to touch on that. About 15% of all strokes are going to be intracerebral hemorrhage, and this is a large hemorrhage that you see here. And you can see actually edema all the way around the hemorrhage and midline shift. So the structures are all shifted over and the ventricles are compressed. You see how it's pushed down on one side? There's a 6.4% risk of getting a hemorrhage with any dose of TPA. The most common causes of just bleeding in general are advanced age and hypertension. Hypertension is the #1 cause of intracerebral hemorrhage. It's also seen with methamphetamine use and cocaine abuse, and that's because of just the amount of pressure that they put through their system. And it's also usually a younger age, overall, in general, than ischemic stroke. So intracerebral hemorrhage tends to occur slightly younger than ischemic stroke. So subarachnoid hemorrhage, the hallmark signs you want to be looking for is someone who presents to the emergency department complaining of the worst headache of their life. That's what you're looking for. So they have new onset, they may have stroke-like symptoms, but 50% will die before reaching the emergency department. 25% will have a permanent severe disability, and 25% will actually get lucky and return to normal function. So I just want to talk about the imaging findings associated with subarachnoid hemorrhage. Again, it looks kind of like a star shape or a starburst and somewhat marbly in the brain, because all those little black spaces fill in with blood where the CSF fluid would normally run. And we do something, you'll hear the radiologist or the neurosurgery team talk about fissure grading, and that's important because what they're looking for is on the scan, is there no hemorrhage? That's a fissure grade 1. Fissure grade 2 is subarachnoid hemorrhage that is 1 millimeter thick. So one slice, that's it. That's all you see it on. Subarachnoid hemorrhage that is greater than 1 millimeter thick is a fissure grade 3. And fissure grade 4 is subarachnoid hemorrhage with intraventricular hemorrhage. And so how many of you think there's greater vasospasm? Which one is the highest? I would say 4 too if I didn't know better, but it's 3. It's actually 3. Fissure grade 3 has the highest rate of vasospasm. And so that's important to know. If it decompresses into the ventricles, you actually have a lower rate of vasospasm, which is interesting, right? But good to know as a nurse. That's why imaging is important. So vasospasm, again, the highest risk of imaging is 3 to 14 days after subarachnoid hemorrhage, but it can be up to 21 days. That's why you see us dosing with nimodipine. And the fissure grade 3 is actually the highest. You also see at our hospital, our nurse practitioners, Joan or Lori or one of the others that's trained to do transcranial Doppler, combined do transcranial Doppler. It's a great screening tool. It's non-invasive and it actually uses natural windows, usually the temporal bone, which is thin, and you're able to look into the brain and look at the velocities of the vessels to see if the velocities are very high, you expect that vessel is actually very narrow because you're running a lot of blood through a very, very tight pipe. And so that's what we're looking for. It's a screening tool. And once we see that, sometimes they'll send them down for CTA and or angio to confirm that and then decide whether or not they want to give them medication intra-arterially to try to open up the vessel. So CT angiography provides excellent detail of the anatomy, but it doesn't really provide any data about flow dynamics. It's dependent on the timing of the bolus. So if you give a bolus of contrast and you time it wrong, you don't get a great idea of what's going on arterially. Sometimes you get venous artifact. So you really have to time very carefully the bolus. And it's the highest dose of radiation. So if you think about, oh, we'll just get a CTA, and then tomorrow we'll get a CTA, and the next day we're going to get a CTA, that's a little bit worrisome because you do have every single day that high dose of radiation. So we really very, very carefully kind of dose out who we're gonna give a CTA for, because if we do them daily, we end up with a very, very high dose of radiation over time. Digital subtraction angio, that is actually when they make a little hole in the groin and go up with a catheter and shoot contrast into the vessels and look to see what's there. It's the gold standard for detecting vascular abnormalities, and it provides critical information about flow dynamics and the surrounding vessels. What you see here is actually badness going on, right? So here is the carotid artery, and you see an extremely tight stenosis, right? I mean, so this is someone who needs a carotid endarterectomy yesterday. And so this is someone I would definitely keep my eye on and think about an antiplatelet agent, making sure that they're protected from stroke, because that's a really, really, really tight vessel. It does require contrast, and there's also a fluoro dose to think about. So we follow how much radiation these people get too that end up with angios. And it provides great information about flow dynamics because you can actually inject and see where it goes based on the flow. So that's important. So aneurysmal, I just want to show you a picture of a patient that we treated. And coil embolization, when you coil a patient, you actually take a catheter up, just like you would with an angio, and you get to where the aneurysm is, and you go into the neck of the aneurysm, and you begin to fill it with coils like stuffing a trash can. And so you get it as much full as you can and then pull back. And they actually have different types of coils. They have framing coils that provide a structure and then filling coils that are a little bit softer. And so there's a lot of important ways, and it's very, very detailed, so I can't go into it here, but I do want to show you some pictures. This is a picture of a patient that got treated with coil embolization, and you can see here, this is the next one. It looks okay, and then we come back and we get our follow-up 6 months later, and look, the aneurysm has recanalized. Do you see it? And so here's all of our coil mass, and here's the aneurysm again. And so this is someone who needs more treatment, and so this is the final treatment. Do you see that? This big ball of wire? And I want to tell you that I think that a lot of the coil embolizations that we are doing now may go to flow diversion. Have you guys heard of flow diversion? So now, with a lot of more challenging aneurysms, we're actually putting a flow diverting device. Looks like a heavy stent that doesn't have, like your normal stent had a lot of wires. You could see in between. This is a very tightly packed stent that just diverts the flow. And so it completely diverts the flow in the correct direction away from the aneurysm. And then the aneurysm over time just shrinks. It's really a beautiful, very elegant treatment. And so I think that going forward, as we gain more experience with that, you may see more and more people being treated with flow diversion. So quickly, hydrocephalus is really, really, really common. And it's the most common reason for pediatric neurosurgery. It can be communicating, obstructive or normal pressure. And so here what you're seeing is a large, very, very large ventricles. Do you guys see that? So these ventricles are not normal size, they're big. And so communicating hydrocephalus is actually failure to absorb the CSF. And we see that sometimes in subarachnoid hemorrhage because the villi, the arachnoid villi, become clogged up with blood during the subarachnoid hemorrhage, and they no longer function after that. So then people have difficulty with developing hydrocephalus. Obstruction occurs sometimes because of tumor, and then sometimes you can have overproduction of CSF, and that sometimes happens when you have a tumor of the choroid plexus. The choroid plexus is a structure in the brain that makes CSF. So if you get a tumor there, you can just keep making it and making it and making it, even though you don't need more. So this is communicating. This is an example of obstruction. Do you guys see the tumor right here? And this is one of the risks I want to talk about. So what is the treatment sometimes for hydrocephalus? Sometimes we'll put in a shunt, right? And so in older people, they have little bridging veins. Their brains begin to atrophy a little, but they have little bridging veins that are connecting their brain to the skull. So when you put in a shunt, you sometimes pull all the fluid off, and then it pulls the brain down a little, right? And so when it pulls the brain down a little, you can end up with this, which is a subdural hematoma. Do you guys see it all the way down the side? Because of overdrainage. So anytime we're diverting CSF, we have to worry about overdrainage, and you should be careful about that. So just to look at this scan, do we see any blood on the scan? The answer is yes. We see blood all the way down. All the way down, it's a subdural hematoma. How about the cisterns? You can see just the lateral ventricles on this. The brain appears to be pushed over to the side, and there appears to be some swelling on this side. And then the ventricles, you can see compression of the ventricles here. And then the bone itself looks okay. Okay, let's turn our attention quickly to brain tumors. So the lifetime risk of developing a brain tumor is actually relatively low. It's 1%. The cause of brain tumors developing is really unknown. It represents 2.4% of all cancers. And the survival is really tied to the completeness of resection. So if you can get all the tumor out, then you're more likely to be successful with managing the brain tumor. So imaging in brain tumors, some tumors really have a radiographic signature. So meningioma, acoustic schwannoma, they can largely be identified based on just their imaging, although we can never completely be sure unless we have pathology. Low-grade astrocytoma is generally non-enhancing, and it's seen best on an MRI with T2 or FLAIR. And then high-grade glioma usually has central necrosis, and I want to show you some examples real quick. So what you see here is you see a dumbbell-shaped tumor. I'm going to point it out right here. Do you see it? It's at the level of the 8th cranial nerve. And what does the 8th cranial nerve do? Hearing, right? Hearing. And so what this is it's actually, and it's always like homogeneously enhancing, really, really bright. So that's important to know. And that's an acoustic schwannoma is what that is. So the next one I want to show you is actually a tumor that it looks like it goes along the top of the brain, right? So this goes along the top because it's hugging the meninges. And then here, again, this actually is right up against the meninges. It's a big tumor, but it's up against the meninges. It's homogeneously enhancing, which means it's all white. There's not like pieces of white, pieces of black, gray. It's just all white. And then it also is extradural, and it also has bony involvement. Do you see that the bone is involved in this tumor? And look at this bone. This is hyperostosis. That's what we were talking about earlier. And there's also calcifications. And so that type of tumor is called meningioma. And again, just looking at our acronyms, you're looking at the blood, you're looking at the cisterns, you're looking at the brain itself. You look at the ventricles to see if there's any problem with the ventricles. And what's interesting about meningioma is, look, these ventricles look pretty symmetric, right? Even though you have this kind of big thing sticking on top of your head. And that's because it grows so slow. When the brain, when tumors are growing very, very, very slow, the brain tries to accommodate. It's kind of like somebody trying to sit next to you or sit sort of on the side of your chair, and they keep scooting over and you keep scooting over, and it's the same thing. Okay, now this one is the one I was telling you. I think that you should look at a CT scan and an MR together. And this particular type of tumor is heterogeneously enhancing, and I want to point that out to you. Do you see that these are all different colors here? And there's this big black part, and there's this gray and white. So this is heterogeneous enhancement. There's also pieces of central necrosis. There's also cytotoxic edema, and it's also crossing midline. And this particular tumor is glioblastoma. So spine imaging, just quickly, because Dr. Panchal is going to touch on this. The hallmark symptoms, of course, of cervical degenerative disc disease are neck pain with radiating arm pain, shoulder pain, numbness and tingling in the hands or the arms, difficulty with hand dexterity, balance problems, and hyperreflexia. And so what you want to look for in imaging studies is the alignment of the bones and also whether or not there are discs that are pushing and also osteophytes in the back that are pinching. And so what you see here is a big disc osteophyte complex. Do you guys see that here? And this tight spinal cord. So here's the spinal cord running down, and you see how it kind of pinches here and then keeps going, and there's almost like a white look to the spinal cord there. So that spinal stenosis at that level. Lumbar degenerative disc disease typically presents with radiating pain down one or both legs. It's often described as burning, and there's weakness of the legs or numbness and tingling of the legs, difficulty walking, sometimes foot drop, or bowel and bladder incontinence. And so if you're looking at the spine, this is another good example of degenerative disc disease. See, perfect disc, nice fat disc with white in it. Here you have lots of water in the disc, and then that doesn't look so good. That's kind of flattened out and black. And then this is really not good because you have a big disc pushing out. And those people will often present with unilateral or bilateral leg pain, and it runs down the leg. People who have more leg pain than back pain are more likely to do well, have a more favorable result with like a microdiscectomy or spinal surgery, because we can often relieve the leg pain, but we may or may not relieve any back pain. So pearls for neuroimaging, things I really want you to think about. Never look for the finding that you expect to see, because you'll miss a lot. And also use a very systematic approach. And then read the report. Once you've looked at it, at the imaging study, read the report and try to find what they saw. And always trust your exam. If the patient is worse, report it. Don't just believe, oh, the imaging looked okay. Make sure that you're reporting it, because maybe more investigation is needed. And lastly, just to remind you, we have our Neuroscience Nurse app, and we'd love to have you take a look and give us your feedback. Thank you.